Dr. Sara Kirby is the Assistant Medical Director for Pediatric Emergency Services at Florida Hospital for Children, and she will join us to talk more about the services that Florida Hospital provides and also the education for Amoeba awareness. Dr. Kirby.
Good morning. Thank you for having me today. So I'm going to be talking a little bit about how the emergency departments have been kind of improving things as far as the protocols and procedures for recognizing and treating the amoeba encephalitis. Dr. Hernandez is our medical director. He unfortunately had a mandatory meeting out of town today. Otherwise, he would have been here as well. But I will be speaking about this, and please interrupt if you have questions. Otherwise, we'll wait to the end, and you can stand up and ask questions after that. So the emergency department, we see complaints of all kinds. So part of the difficulty is picking out the 1 or 2 cases that are actually very serious and very dangerous out of all the patients that come in. So one of the few important things is education and awareness. So we've been trying to increase the amount of education on this entity and awareness of it throughout the whole system, not just in one ED or 2 EDs, but across the board. So all of Florida Hospital emergency departments. So part of that is to create prompts in the system. We have a system called Cerner, that's a computer system, and there's a way to create an alert that comes up. So we've created new alerts, new prompts to remind all the staff, nursing, providers to think about the possibility that there could be an amoeba exposure. So when someone walks in with certain symptoms that we've already talked about this morning, so headache, fever, photophobia, they should be thinking of this and asking certain questions. So in the computer system itself, it'll actually pop up a little box that says, think about freshwater exposure. Think about exposure to certain types of water. Think about the possibility that this could be happening in this child presenting to the ED. So from the ED itself, we talked about that. We also have a prompt that the lab talked about briefly this morning, that every time you order a certain test, so the way that it happens is someone walks in with symptoms of possible meningitis or encephalitis. One of the things that the provider has to do is think about doing a test, which tests for the spinal fluid. When they do that, they have to actually order certain tests in the computer and remember to order them a certain way. So that's something that's very difficult to remember in a very, very busy shift. So we've made it easier, and now when you order that test, the CSF test, it'll actually alert you to think about ordering this special test from the lab. So it makes it a little bit easier to remember to order it, and it's a mandatory field now, so it automatically comes up. The last thing that we've done as well, and this is kind of the big thing that I'll be talking about, is we've created a clinical pathway for the providers themselves to help improve the rapid diagnosis and treatment. So one of the things that we've realized is being really aggressive with the treatment has seemed to be very beneficial. So not only thinking about this diagnosis, but also thinking about the steps needed to treat it is very important. So the team of doctors and staff and administration at Florida Hospital have created a pathway, and it's on SharePoint so anyone can get to it to help them figure out each step that needs to happen, and they don't have to remember it all from memory. So this is kind of a busy slide. I'm sorry it didn't show up quite as well as I had hoped, but just going through it to kind of see how there's different steps you have to think about. So when you have it laid out in this fashion, it's a little bit easier to remember to do all the steps that's needed. We've also created a way for the whole system itself to be involved a little bit quicker. So as you can see here, you have a few steps that are a little bit confusing, but if you look at it, it kind of goes through in a very systematic fashion. So if you have a child that comes in with symptoms of meningitis or possible freshwater exposure, then you're supposed to be thinking about doing what we referred to before, the lumbar puncture, and getting certain test orders. And I mentioned that prompt that comes up, that little box that pops up that says, remember to order this certain test in the lab so that they can look at it. So that's part of this flow chart here. The other thing that this flow chart shows is that when you think that the lab has called you and said, this is actually a positive test, you actually will call the transfer center themselves and get them involved very early in the process. So I know the lab has done a lot of education and a lot of preparation to make sure that they're looking for this test in a timely fashion. When the alert is ordered to look at it for the amoeba, it is something that's done very quickly. So the phone call to the provider will actually happen in a very timely fashion so that everything can get started and make sure that it's starting in as fast a way as possible. So as far as if they think that it possibly could be ordered, they'll actually have the pathologist come in as well, not just the tech to look at it, and they'll actually try to confirm as best as possible, as quickly as possible. It'll then create an order to actually look for the specific test for the actual organism that would actually have to go to the CDC. Now, when all this is happening, you've actually talked to the transfer center, and the transfer center has already started to create a process of notifying everyone that needs to be involved. So part of the process that we're working on is actually trying to get the CSF from one campus to south, the main campus, to better accurately diagnose the amoeba. So that's something that they're working on right now. What we already have in place is that if this does happen in one of the ERs, they will call the transfer center, and that's that main kind of communication hub in all of the EDs. And the communication hub will then start making phone calls. So it won't be one person making 15 phone calls. So one of the things that happens when you're in a busy emergency department is there's a lot of things going on. So to expect one person to make 15 phone calls in 5 minutes is very difficult. But there's only certain people that really are kind of qualified to make these phone calls. So having help from a center hub is actually very, very beneficial. So we have a transfer center that's involved, and they're gonna actually start calling all the team members across the system to start letting them know as things are happening. So you have the team members talking to the PICU, the entire ICU intensivist team. You have them talking to the lab, you have them talking to the transport team. The transport team is very important in our plan here because they actually can physically go to any of these campuses. So ideally, if children have these symptoms, they would go to the pediatric emergency departments that we have set up at the main campus. But people go where it's closest. If they don't have transportation, they may even walk somewhere or get a ride somewhere. So they can show up anywhere in our Florida hospital system. So getting teams to these EDs is very important. So we actually have the transport teams that are ready to go out to these systems now to help manage these patients earlier on and not later. So that's being done. They'll also make a call to the CDC and get them involved. All these things take several minutes each. So anybody that you have helping to make the phone calls makes it much faster. So they'll be talking to the CDC, they'll be talking to the infectious disease doctors at Florida Hospital. They'll be talking to the other neurology teams, neurosurgery teams, getting them involved, at least aware of the case that is going to be, if not in our ED at the moment, but coming to the ICU at the main system. So along with that, as we talked about the transfer team, these actually can come to each of the campuses and not only go to them to help support with care, they can also support with medications. So the transport team is trained, they have critical care, paramedics, nurses, everyone else that can help support someone that may not be very, very comfortable dealing with a very sick young child. So they'll actually be there at the bedside to kind of help with the care of the child. What they'll also be doing is bringing medications. So as we've talked about before, medications are extremely important in the treatment of this disease. They've done tons of research, tons of investigative reports with FDA, trying to find the very best system of treating the amoebic encephalitis. So we've come up with a care plan as far as medication treatment that everyone should be initiating when we have a positive amoeba test in the CSF. So these meds are not everyday meds. So it's not something that someone might be comfortable figuring out on their own or remembering from memory or trying to do without help. Again, like I said, the ED is a very busy place, so having as much possible help and support as possible is very good as far as for patient care. So the medications that we're recommending, not all of them are stacked in every one of the Pyxis. So as we've had conversations before, some of these medications are a little bit more rare, and the foundation does an amazing job of making them more available. So we've actually created a system where the transport team will bring one of the medications with them to give immediately there at the bedside in the ED. So right away, the ED should be able to give several of the medications that are more common. So the azithromycin, the fluconazole, the rifampin, the steroid dexamethasone, and even amphotericin should all be able to be given in a timely fashion while waiting for the transport team to get there. The one medication that we're referring to that's more difficult is the metefacine. So that medication would actually be given with the transport team to the ED as soon as possible. The goal is to give that medication by mouth before anything else is done to make the patient unable to take the medication. So ideally, someone presents to the ED fairly early on in the presentation, and we can actually give all these medications to swallow before they have to do any sort of aggressive therapy, such as intubation or inducing a coma. So all these things are kind of be happening all at the same time with the help of the transfer center and the actual main hospital at the children's campus. So hopefully this will actually make things easier on not only the hospitals that are close by, but also more far away that maybe don't have the resources that we have at the big downtown campus. In addition to doing all of the education, awareness, and just kind of making people think about it every time that there could be a possibility of the disease. So at this time, are there any questions about the care plans that we've created? It's kind of an evolving process. You know, it's something that we are constantly updating and amending and making sure that we're up to date with all of the current CDC guidelines and current recommendations to try to make sure that we're doing the dosing correctly and the timeliness of the medications and the treatment in as quick as a fashion as we can. So it's definitely a team effort. It's a team mostly from the Florida Hospital for Children, the intensivist, the infectious disease, the ED, all creating the best possible plan for the patient at the time. In addition, you know, we have the transfer center that's available all the time, so even if there's questions about this system, they're welcome to call and ask questions about maybe starting it earlier or not sure when to call. They're happy to answer all those calls as much as we can. Any questions, comments, or I have a microphone if anyone needs it. So, as I said, this is something that we've been working on, and we're pretty proud of what we've come up with so far. But again, any suggestions that people have, we're happy to take them as well.
So I have a question. In the future, should a point of care test be developed that you could keep on site? How would you see that affecting this care plan?
That would be amazing. I think if someone was able to develop some sort of quick test for it, obviously it would make the whole plan happen even more quickly and more expeditiously to develop the treatment for it. So I am sure that there are people that are trying to work on that, research teams, trying to develop the best possible test. We're actually, you know, in the ED, there's very few tests that we get back very quickly, like at point of care. Any ones that we have, we're extremely thankful for. But I definitely think that if we could develop something like that, that would be beneficial for the patient, absolutely.
And do you think that would make ED physicians more likely to consider this diagnosis and order that test, just because it would potentially be so much more readily available, rather than it having to be sent to us at CDC and you have at least a 24 to 48 hour delay?
So, you know, I guess as far as testing goes, it's always kind of a double-edged sword. Like, you don't want to have false negatives, false positives, things that kind of skew the actual treatment. So it's not that we don't like to order tests on everyone, it's just that we have to consider the possibility that a test may not be 100% accurate all the time. So I'm assuming that you're kind of referring to maybe like a blood test instead of a CSF test. Is that something that you're, yeah. So, you know, they have been able to see some amoeba in the blood in some studies that I've read, but as far as coming up with a quick test, we definitely don't have that yet. As far as ordering it on every person that came in with any possible symptom, like if every patient came in with a headache, would you order this test on every single person? I would say not necessarily, because then you run the risk of having the false positives and starting this cascade of events. However, if there was a test that was a little bit quicker and easier to run, I do agree that it would be better for the patient.
Thanks, Dr. Kirby. That was great. So just an update.
Yes.
So Sheila, Maria, and I have worked together to create a policy for our laboratories in the Florida hospital system. So there is now a policy to transfer the CSF with the patient, because unfortunately and fortunately, we had some false positive patients that we were able to go in through a debrief with our transport team and try to identify some of these issues. And for the testing, again, I'll point to Sheila and Maria. We have worked with AHS lab directors and are continuing to train people in the outlying facilities. And I don't know if Sheila or Maria wants to say more about that, but we are making the test more readily available and knowledgeable, and with the hard stop on meningitis when they have to ask whether it was freshwater exposure, we think that that is going to help.
Yeah, I know you've been working hard on this from the beginning, Susan, so definitely thank you for all your hard work and perseverance on getting this accomplished, and again, updating as often as we can to make it even better. Anything else? I know we'll talk a little bit more this afternoon about treatment, so we won't belabor that point, but I appreciate your attention, and yes.
Just a quick question. When you have it set up in Cerner, does Cerner make that care pathway available to other hospitals after what you've already been accomplished, or is that just specific to AHS?
So each hospital system has their own computer systems, unfortunately. So everyone chooses to go with a system that they think is the best option for them. So it's not a universal computer system. So, and anyone that has Cerner can't necessarily get to this care plan because of the way that Cerner's set up is not the same in every place. So ideally, I think the good system that they have in the VA, everyone can see everything, right? So that makes help a lot of people that can look at protocols and plans and treatment and options and histories. Ideally, we'd all have the same system, but unfortunately we don't. But as far as the education and awareness, making the fact that we have a care plan known and that it's available is always helpful for other systems. They can, and as a children's hospital ED, we always welcome any phone calls from anyone. So day and night, we're always there, and we always welcome any, and we try to promote that. Please call us with any questions, concerns, and you're not sure how to do something. We're happy to answer those phone calls all day long. So unfortunately, the phone call, as antiquated as it is actually still kind of our best option as far as communication goes. But yeah, I agree that having some sort of central access would be ideal. All right, thank you again so much. Appreciate it.